what are the key issues for child health and reducing health inequalities in London that the Mayor should be focusing on?
Well, obviously the issues are multiple, and I think that would be the first thing that I would want to highlight, that if we're talking about a healthy start for babies and young children, it's about bringing things together rather than picking off separate issues. As an organisation that's working in the early years of life, we would say that getting in there right at the beginning is crucial. So sort of pre-birth, from birth, and aiming to get children off to a healthy start rather than deal with the consequences of of that early health not being established. So really building healthy eating and activity habits, building emotional well-being and development through all of the policies and actions. And I think, you know, particularly in those early years, we need to be looking at the family environment, because children are born into families, and the start that they have will depend very much on the emotional well-being of their parents parenting efficacy, and the lifestyle habits of the whole family. So really thinking about supporting that environment around the child.
Great, thank you. And Emily?
So I think for our paediatric members, we carried out a report which we published last year, which looked at the effect of poverty and austerity that were having on patients that were coming through the door. And it showed that there was kind of a clear link that more paediatricians were having to deal with parents who couldn't afford to come to clinics, parents who couldn't afford some of the treatments that were required on prescription. So the healthy early years is really important, but poverty is, if children are living in poverty, and I think it's estimated that there are around about 600,000 children in London who are living in poverty. So that's a much higher proportion. So it's about 37% of children in London who are living in poverty. That's a much higher proportion than other regions in England. So that poverty can have these inequalities very early on in life can have a huge impact later on in life. So if you're born into poverty, that can, the detrimental effect and damaging effect that can have in terms of your access to really good quality food and being able to access services, etc. That's having a detrimental effect on the outcomes for children and young people, and as they move into adulthood later on in life. So I would agree with Kim exactly that getting it right at the beginning is really important. But the other thing I would add as well is it's really important to ensure that women before pregnancy that they're healthy during pregnancy and immediately afterwards. So it's about making sure that they've got the right access to supports. That includes making sure that they're the right weight, making sure that they are accessing, if they're smoking, they've got access to smoking cessation services and are helped to stop smoking. But also, once they give birth, they have a baby, that they're encouraged to breastfeed as well. So we know that breastfeeding really does give children the best start in life, but our breastfeeding rates in the UK as a whole, not just in London, are really poor. So we need to make sure that women are properly supported to start breastfeeding, but to continue after the 6-week point, where a lot of women tend to the actual rate tends to drop off. So making sure that women continue. We're
going to look into there are specific questions on breastfeeding later on. We'll come to that.
Great.
Yes. Carly?
I would say from Best Beginnings perspective, obviously we recognise the social determinants of health, and we have a focus on trying to give children the best start in life and reducing health inequalities. But we see a lot of mental health issues for mums, the feelings of being isolated, the lack of social support and networks, and we feel that access to useful evidenced information that's easy to understand and has quite a young reading age, say from 9 upwards. That's what we tend to put into our Baby Buddy app to make sure that it's tonally correct, and supporting women with the right services, and then helping them to feel confident and empowered. If you've got an empowered parent, then they're going to feel happy about making good choices for their children, and it's about trying to support that mindset.
Great. Geraldine?
I think from a health visiting perspective, my background is midwifery and health visiting, and I think that transition to parenthood is an incredibly crucial time for parents. I think it's such a unique time. There is no manual out there as to how you do it. So I think it's incredibly important that we have the services in place and that we have the well-trained staff who are actually able to support parents in thinking about those risk factors and vulnerabilities. I think from a health visiting point of view and thinking about child health and about those health inequalities, I think housing is huge, has a huge impact on children and poverty. I think it's incredibly difficult for parents to listen to those health messages if they have other agendas going on in their lives, like poor housing, struggling with finances, not able to afford basic things that their children need. So I think it's such a complex. I think it's such a complex agenda, and I think I would agree with everything that's been said so far. I think we have a society where there are such complexities around mental health and thinking about how we support children. And I think certainly our focus needs to be absolutely that the child is in the centre and thinking about how we improve those outcomes for children.
Yeah, George?
Yes, I think the committee members will have received a paper from me, I don't know if you've had time to look at it yet, in which I highlighted that I think that in an excellent draft health inequalities strategy there is a major omission, and that is attention to the issue of adverse childhood experiences. By adverse childhood experiences, I basically mean 10 identified events that take place in children's lives that have been very thoroughly researched in the United States and recently in both England and Wales. And those are various forms of abuse, physical, emotional and mental, physical and emotional neglect, children growing up in homes with domestic violence, with substance abuse, with parents who have mental health problems, children who have lost a parent through divorce or death, and children growing up in a home with somebody incarcerated. As I also indicated in that paper, if you look at the research, which is powerful and stunning, there are over 80 health consequences or lifestyle consequences that can be directly attributed to these issues. It has a major impact on heart disease, liver disease, lung disease, diabetes, obesity, cancer, a whole range of mental health issues. In the American study, 1 in 7 people had 4 or more of these 10 categories of ACEs. In that group of 1 in 7 of people, levels of alcoholism were 6 times higher than those for people without ACEs. Levels of drug abuse were 11 times higher, and attempted suicide was 14 times higher. In a recent study that I've seen carried out in California, children in school with 4 ACEs or more were 32 times more likely to have learning and behaviour problems in school. What it essentially means is, to a very large extent, the children who are struggling in our schools, the children who are not school ready, the children who are disrupting the learning of other children, are those who've suffered adverse childhood experiences earlier in their lives. It is preventable to a very large extent. WAVE is running a prevention of ACEs project. ACEs is the term used for adverse childhood experiences. WAVE is running a prevention of ACEs project in Northern Ireland. I think that prevention of ACEs should be a #1 priority for the Mayor and the Assembly. But I would like to add a second point, and that is about health visiting. I managed to get hold of, for this meeting, and I can circulate afterwards, a summary of the state of health visiting in London. It was quite difficult to get hold of it, but it's been arrived at by a survey carried out by the Institute of Health Visiting. And some of the figures in it I consider very disturbing. So, for example, 45% of health visitors in London have caseloads of over 500 children against the England-wide recommended caseload of 250 children. 93% say their caseload has increased in the last 2 years. The 3 to 4 month assessment, which is absolutely vital for attachment and mental health assessment, is only being delivered to 11% of families in London. A majority of parents in London do not see a health visitor after the baby is 6 to 8 weeks old. 55% of health visitors don't have a specialist health visitor for perinatal and infant mental health that they can refer parents to. 31% are concerned that there may be a tragedy in the safeguarding realm because they just don't have enough time to look after it. It is, I think, a terrible blight that health visiting is turning in this way. 2 years ago, the government had just completed an increase in number of health visitors across the UK. Since then, there has been a very major drop in health visitor numbers. This is happening at a time when Scotland is adding 500 new health visitors to its load because of the recognition of the critical role of health visitors in the early years. So this is certainly something that I would signal as of the utmost importance.
Well, Joyce, thank you very much for making the contribution in terms of sending your paper in and also for highlighting health visiting. We are going to pick up health visiting later on in more detail, okay? There's specific questions to it. And we will pick up these numbers and dive more into that. But it brings us very conveniently to you, Robert, right?
Yes, rather, yeah. Well, of course, I mean, all the other guests I would agree with everything that they've said, and George has made some detailed comments on health visiting. So I suppose what I would just pick up, which I think in support of the other comments that have been made, for London particularly, in terms of inequalities, this Sir Michael Marmot, who is, of course, a world authority but based here in London, he talks about the social gradient for a whole host of different indicators. And of course, for London, that gradient is particularly steep. So, and one of the things that he points out is that affects everybody, not just the people who are at the bottom of the pile. So, to zoom out from the micro to the macro again, although, of course, in some ways that's the most difficult area, but it's also where the most potential lies, to reduce the steepness of that social gradient. And that manifests itself, as colleagues have said, from the outset of life. So then, in terms of coming down from that kind of macro level observation, I think something that is a golden thread, really, that runs through what so many other people have said, is that when babies, infants come into the world, key to their health outcomes is the quality of relationships that they experience and those around them experience. So it's already been pointed out that somebody who is subject to those problems such as mental health, alcohol, domestic violence, and so on, multiple stressors, housing challenges, is much less available to respond to the needs of their infant and child. And likewise, for that parent to have access to networks of support, be they community-based within their own family and so on, and to have access to trusted and authoritative help from whatever source that may be. Health visiting is part of that picture from the early years, so from the earliest years. And I think key is that it's not just about a matter of having a provider model that parents, it behoves parents to access a service, because the transition to parenthood that was referred to by Geraldine just now is a time of great optimism very often for many families, but also great vulnerability. It's very hard sometimes to recognise or to request help, particularly if you're lacking in confidence or unsure of yourself or isolated. So having proactive services that are organised around where children and parents live, which is in their homes and in their communities, is key. So not a come to me approach, but a go to you approach.
Great, thank you. If there was one priority for the Mayor to have, right, in addressing, what would that priority be? You probably mentioned already in your, but I just want to formally, for the sake of recording this, is if there's one priority that the Mayor should be focusing on, what should that be?
The beauty of the Mayor's office is the opportunity it provides to develop a joined-up long-term strategy for London, an overarching sense of sort of driving, leading, that makes the best use of investment that is already happening in the boroughs and drives the implementation. And I mean, as Henry, we're doing a lot of work across London at the moment, but it's bitty. I think if I had to pick one thing that I felt that this opportunity to really bring things together would be workforce development. That there's obviously, in a city the size of London, a huge workforce out there who have contact with families on a day-to-day basis as part of their roles. And we can really maximise the opportunity that those staff have by providing that workforce with some high quality evidence-based training so that they're making the most of the opportunities. And it's not just about giving consistent messages. It's about how do we work with families in a way that builds their confidence to provide a healthy start for their children, that builds their motivation to change their own lifestyle or to address issues in their lives, that these adverse childhood experiences that we've been hearing about, builds their motivation to do something about that, and also engages them with active partners, as active partners in their children's health. And that isn't just about, I mean, we hear an awful lot about making every contact count, and one of our real concerns is that that's often giving a leaflet or giving a piece of guidance, and that there's a lot of focus on if we can get the key messages consistently communicated, we've somehow done our job. And it just isn't enough. I think we sort of all know that it's about how does everybody, this sort of support around the child and around the family, how do those practitioners, whether they're health professionals, whether they're childcare practitioners, whether they're community staff, early years staff working in children's centres, how do they engage parents and build parents' confidence and motivation to provide that healthy start? Because at the end of the day, it's parents who will provide that healthy start for their children, so we need to engage them and not just provide information.
Did you want to say anything?
So I think it's kind of already been picked up in people's opening statements, but I think tackling poverty and inequality is a really important thing, and the Marmot review of health inequalities has already been mentioned in his the concept of proportional universalism, and I think that it really just builds on what everyone's already said, but there does need to be investment in public health early years services and making sure that families that really need that support are prioritised and it is targeted to the most in need, but making sure that that includes kind of both the join up between midwifery and health services, because sometimes there can be a bit of a disconnect between the two, so making sure that those two really early intervention services and making sure that when women leave hospital after they've had a baby, that midwifery services have had that opportunity to provide those that advice and support, but then that's carried on through the health visiting services as well.
So from Best Beginnings perspective, we've also been exploring this question, and as you may have known from the last meeting, Best Beginnings have an app called the Baby Buddy app. Medically evidenced information. It's considered a public health initiative. It has over 200 films in it, including 17 specialist ones that are for training maternity professionals around how to have challenging conversations around maternal mental health. Picking up on what Kim was saying, I think it's really important to train professionals so they feel equipped, that they're able to have some of these tricky conversations. I mean, how do you even begin that conversation of, are you feeling okay? Or how do you find out what some of the cues might be to be able to use an appreciative inquiry and explore and have a moment that's boosting the relationship and trust between you and this person who, due to potentially lack of continuity of care, you might never have met before. I think this is something really challenging that needs to keep being explored. One example of where we use film as a catalyst for change and it's become effective is there's something very powerful about mums and parents watching films of mums sharing their experiences through a difficult moment or the baby blues or postnatal depression. Shabira, who is the COO for Best Beginnings, had an experience with the Bangladeshi community in East London, and she saw the power of film as a catalyst for change in this moment. They watched a mother talking about her mental health experiences and how she overcame, and although Shabira had a history of working with this community in East London for over 10 years, this particular film seemed to open the floodgates and created an overwhelming emotional response from the women in the room. So there's something very powerful about peers watching others and listening and thinking, well, I'm not alone in this. So I think we need to explore some of the digital and other resources that are out there that enable peer support for patient activation, because we are actually talking about individuals being able to be confident and make decisions for themselves. But they can only do that if they feel empowered and safe. And so there's kind of two aspects, aren't there? The fact that the individuals get a chance to explore for themselves how to become empowered and confident and given the right information. And then on the other side, that we're training professionals to be able to build relationships and have challenging conversations, and hoping that that would boost along and help with outcomes more long term.
Thank you.
I think an absolute priority has to be maternity care. We have 17 babies are born every day in this country, stillborn. And I think for those families, their trajectory and their life journey is completely altered following an event like that. So I think we really need to think about investing and how we invest in
Did you say
services.
70 or 17?
What number was that?
Huh?
17
17
in
17
London
babies
or
in this
UK?
country.
Oh, in
This
UK.
country.
In this
Thank you.
country are stillborn every day.
Yeah.
So I think we absolutely need to get it right from the very, very beginning. What we need are healthy babies and healthy mothers and healthy family units. So I think that would be absolutely my priority. I think the midwifery services, they need to be, as we've talked about, training. That's incredibly important. But we need staff. We need the staff that can have those relationships with parents. We know parents tell us they don't want to keep telling their story to different professionals, and that happens all the time. And that continuity is so important. Parents need to feel safe. They need to feel that they can trust professionals. And that's a process. It's not something that happens. When you first go into a family, the first time you meet them, you know, you're just at the very, very beginning of that relationship, and parents will not disclose to you. They need to know that they feel safe. They need to know they can trust you. And I think at the moment, I think that's very difficult with our midwifery services. I think it's a real challenge and a struggle for them. I think women don't get the continuity and just having the space and the time to develop those relationships. So I think that's a real priority.
Thank you.
For London.
George?
I'm a clinical criminologist, and I came into this field of interest in the early years through my work in criminology, because I identified that the origins of violent behaviour are to a very significant extent formed in the first 3 years of life. In fact, the future violent teenagers by age 1.5 to 2.5 are already 10 times more aggressive than peaceful 2-year-olds. What is of concern to me is that every year in London, about 20,000 children are being born who are going to have disorganised attachment. That's the very worst form of attachment that one can have. If you look at the number who are going to suffer significant numbers of ACEs, and if you took the American study of ACEs, again, we're looking at something like 20,000 children a year with 4 or more ACEs. The impact of 4 or more ACEs is devastating for physical health, which leads to huge lifelong costs in our health services. It's even more devastating for mental health. It has huge impact on school readiness. It has huge impact on children's behavior in preschool and school. It feeds into school exclusion, truancy, petty crime, violence, aggression, and future perpetrators of things like domestic violence and so on. And we could do something about this. We could do something about it if we recognized the impact of ACEs and did something to prevent it. Now, this is an area that London currently seems to know very, very little about. It is an area of explosion of interest in Scotland, Wales, and Northern Ireland. The Welsh government, early in 2017, January 2017, declared that tackling ACEs was its #1 public health priority, and they've been following through by setting up an ACE hub to create understanding and knowledge of ACEs across the whole of Wales, and educating people and starting to get policy formulated by reference to that. The Scottish Government has also now set up an ACE hub with the same kind of objective. I've also mentioned in the email I sent round to Assembly members the film Resilience, which captures a lot of the research in this and is having a very major impact. Yet last night in the Scottish Parliament, all of the MSPs of the Scottish Parliament were shown the film Resilience because the First Minister considered it was so vital that everyone sees that film and understands the impact of ACEs. More than 400 civil servants in Scotland have been shown the ACE Resilience film. In Northern Ireland, I was part of a conference in November on ACEs, which was decided by the health authorities in Northern Ireland to invite senior civil servants from health, education, criminal justice, social services, and so on. There were 150 places in the conference. There were 600 people applied to attend. The meeting was a whole-day conference. At the end of the conference, it had been set up that the senior civil servants from the different departments were asked to form a panel and draw together their conclusions from what they'd seen that day. Most of them had never heard of ACEs before that day. Their conclusion at the end of the day was that tackling ACEs has to be a top priority in police, in education, in social services, and in health in Northern Ireland. On next Tuesday, I'm going up to Manchester at the invitation of Andy Burnham, the Mayor of Greater Manchester. I'm going to be in a room with his Chief Executive, his Deputy Chief Executive, Lead Councillor, invited to talk to them about ACEs and what you do about them, both to stop them happening and about them after they happen, which is called trauma-informed care. In Washington State in the United States, they have been tackling ACEs for over 10 years. It saves money. They've actually found that when they make ACEs a public policy priority, they save money by doing so. So this is not something that one should not be doing because of the cost. It's something one should be doing because of the cost of not doing it. In Scotland, the government set up a commission called the Christie Commission to look into public services. The Christie Commission concluded that 40% of local public expenditure is only necessary because we don't intervene early enough in the development of problems. It'd be wonderful to see London being a leading city in the world in tackling these problems at the beginning, rather than waiting until things go wrong and then trying to put them back together again.
Well, you make a very powerful plea that London Assembly should be watching this film too, and we'll do something about it, okay? Yeah. Robert?
Okay. Yeah, I'd just like to pick up a term that Emily referred to earlier on, which is called proportionate universalism. But to start with, to reverse the order of the words in a sense, that so the key is universal. the point that George has just been talking about, adverse childhood experiences, they are sadly not rare. They are widely distributed amongst the population. Having 4 or more maybe is less common than having 1 or 2, clearly. But we need to, if we're to prevent and to recognise and to prevent, then we need to be working across the whole population. Every child needs to have this opportunity to avoid or mitigate those adverse childhood experiences, the impact of which is so significant for their future health, development and outcomes. And not just for them as an individual, but for families and for society as a whole. And if we're going to follow the questions that we've been given in advance, I think we're going to come along further later on to the idea of targeting and most in need. If we only focus on those where we know that there are established needs, if we focus on the tip of the iceberg, then we miss the bulk of the iceberg. There is far more need, there are far more ACEs actually occurring just below the waterline than there are above numerically. This isn't an either-or kind of discussion. The term proportionate universalism is around us, every child having the opportunity to have their needs assessed, and every parent having that opportunity to be supported in their role in meeting their children's needs and to build that family resilience, and to have a level of responsiveness that is proportionate to the level of need. And so I'd make a plea that we need to have that proportionate level of services whereby every child and every family has that opportunity to have their needs assessed, met, and to have someone to be supported along that a pathway. I think in terms of what could something like a London Assembly do, there are things that can be done at a sort of more system-wide level that can't be done just at the local level. I actually have come down from Manchester today. George is going to Manchester, but that's where I actually come from. So Greater Manchester, as you know, has devolved responsibility for health and social care and has done some work along this direction already. So in terms of workforce development, for example, across Greater Manchester, the Solihull approach, which is a way of working, it's not an intervention program, it's a very positive way of working, has been rolled out very widely across providers. A particular technique for helping, for looking at early parent-infant interaction called the ENBO, or Newborn Behavioural Observation. That training has been rolled out across most of Greater Manchester through the opportunity afforded by taking a strategic approach to look at workforce development. There's an awful lot more that could be done, but those are just a few examples. I'm aware in London, for example, that a similar example in Croydon, I just happen to be aware that the whole early years workforce there has been trained in the family partnership model, which is an excellent way of developing a common language and set of skills that are around the quality of relationships between workers of different kinds and parents and families. That's been done in Croydon. That's good for Croydon. But I think there is London. I tremble to make too many comments about London because I'm not a Londoner. But it's such a complex picture. with so many interpenetration of communities and pathways and provision. And so I think a key issue that we're picking up as a profession, and has come out in the survey, to which George has already referred to, but survey that it's our survey of health visiting, is the fragmentation of and inconsistency and incoherence in commissioning for children's public health. Now, I find this actually quite bizarre when the whole national narrative is around integration of health and social care. So we have STPs for the health sector. We have Secretary of State is now not just for health, but for health and social care as of, was it yesterday? Signalling a recognition of how important it is to bring that coherence together between the health sector and the social care sector. We're going to talk later on, I think, about the transfer of commissioning, but I would just really want to signal that the feedback that we're picking up is that there is a great deal of fragmentation, which doesn't just affect workers in the service, but makes it difficult for parents to navigate the system, more difficult than it would have been, as we have a host of sort of small princely states, that's my term, for each local authority commissioning at a very local level, with it outside of a national, or say in this case, a Greater London framework. And I don't think that's a thing that we've particularly picked up so far. So I think that is a contribution I'd like to make.
Thank you. Thank you for setting the scene. Now we're going to explore some of the topics in more detail. If I could just make a plea, if we could be very focused in our responses, because we have a lot to go through, and we all have to leave here 5 o'clock, right? If we can. So, Umesh?
Yeah, thank you, Chair. Got a set of 5 questions, and there will be more supplementaries depending on your answers. But if I can start off by asking all of you, the Mayor is proposing a Healthy Early Years program. How do you think this will impact on improving child health, and specifically on reducing inequalities? If I can start off with you, Ms. Roberts.
I mean, I don't know the details of the proposed programme, but from the information that I have, my concern would be that by focusing too much on settings, that we miss the opportunity to actively involve parents, and you know, I mean, I think we've all flagged this, that the evidence shows that programmes that actively involve parents are going to be the most effective. So I think that the early years settings, particularly as children's centre services are reducing across London, early years settings do play a crucial role, but we need not to forget what we've all been talking about getting in there right at the beginning, so from birth, if not before, and also really focusing on parents in the early years.
My second question was going to be about childcare, targeting childcare settings. Was it the right approach to take? So perhaps if we could come to you, Ms. Arkell, and if you could answer both the first question and also what you think about the targeting of childcare settings.
So I think in terms of tackling childcare settings, childcare settings do provide an opportunity to tackle.
So can you speak up, please?
Sorry, so they do provide an opportunity to tackle some of the issues around inequality and poverty. But one of the big prohibitive things around childcare is the cost of it. So that if there's anything that the Mayor could do around the cost and accessibility and availability, I think that would be around the provision of childcare in London, that would be really a real step forward. But also around some of the skills of those working in the sector as well. So I think the early years hubs, which are included in the plan, those could potentially improve access to high quality early years education. So potentially kind of giving kind of a level playing field at a very early stage. So I think those are the key points really around provision, access and availability, and also making sure that the settings, people who are working in those settings have skills, but also that they can provide that kind of early years education as well for young children and babies.
I echo what Kim said completely. But what I would add to that is an intention to analyse data and trends is going to be something that was really helpful, so I was happy to read that. Because having a look at what might be making the difference will give a good steer to what will be effective in the future. I think supporting parents with breastfeeding is a good idea, so it's just a chance to see how that might work. And certainly standardised info, because that echoes previous comments that we've made about how hard it is to be able to find information and just there being a huge amount available and it being tricky to navigate. Just sorry to echo again what Kim said, that the earlier the better, as soon as, preconception. Childhood settings are good, but the earlier you can get the messaging out there, the more support and relationship building that happens, the better. I would worry that childcare settings may be too late based on some of the feedback that we've already given.
I think we need to remember that there's lots of children that are not in childcare settings. So I think my concern would be that actually the programme isn't reaching.
Sorry?
My concern would be that the programme wouldn't be reaching quite a sector of society. We know that in terms of the 3 for 2 offer, that many places aren't taken up in the London boroughs. So these are the children that are deemed as most vulnerable in terms of thinking about childcare. Often parents will say, why do I need to use a nursery if I'm at home with my child? And often it's the children, the vulnerable children that actually aren't in the childcare settings, and they're the children that we want to be in the childcare settings. And I would agree with everything that's being said. There's also the quality of some of the settings. I think that's something that we need to think about and address in terms of standards, and also the training for the staff in the settings in terms of the expectations and the qualifications.
I read the draft health inequalities strategy, and I can't recall anything in it that I read that I disagreed with. So I think it's a good document in terms of the things it's proposing. But do I think that it's identified what the true priorities should be? No, I do not. I agree with the other speakers that we need to start much earlier than childcare. If we think about prevention of ACEs, this is something we've given very specific study to in WAVE, and we've come up with solutions which we worked on jointly with the Royal College of Midwives, Institute of Health Visiting, Local Government Association, Public Health England, Association of Infant Mental Health, Maternal Mental Health Alliance, and these ideas have been scrutinised by the Treasury and endorsed by the Treasury. So it's not because we don't know something about what can be done, but we have to start pre-birth. So there are 4 major risk factors that one can identify which are likely to lead to adverse childhood experiences. One is a family where there is domestic violence taking place. Second one is a family where there is substance abuse taking place. A third is a family where there are parental mental health problems. And these are well known among third sector operators as the toxic trio. So we know the things that are going to create risk factors in families. I'd add a fourth, which is we know that in families where the parents themselves have suffered ACEs in childhood, there is a significantly greater risk of harm and damage being done to the child, because the parent is carrying forward the damage if that damage has not been treated in some way previously. So what should we do about it? What we should do is screen the population on a 100% basis to understand where these risk factors exist. Not to point out future bad parents. That's not what this is about. It's about helping create the best parents that one can possibly have. And to give London the best parents it can possibly have, we have to give the right support to those parents who are going to be challenged by the circumstances that they're living in. And that does need to start in pregnancy. Now, once you've found where the major risk factors are, then there are specific things one can do to support those families. I won't go into those now, or I'll talk at too great a length. Post-birth, there are a number of things that can and should be done. One of these, already mentioned by Robert on my left here, is the Brazelton start, where parents are actually trained on how to interact with their child, and it's very specific because every child is different, every parent is different. It helps the child understand their own particular baby's cues and responses and helps them to respond to it. But for us, one of the most critical things is the 3 to 4 month health visitor assessment. That's a point at which you can evaluate the quality of interaction between mother and baby. And the quality of interaction between mother and baby, whether a baby is, has a parent who is attuning in a responsive and sensitive ways to its cues and its behavior, is one of the biggest single indicators of whether that child will develop what's called secure attachment, which basically means good relationships for life, or insecure attachment, which means not so good relationships in life, or the worst kind of attachment, which is disorganized attachment, which are the children who will cost huge, huge sums of money to the public services in the future. The good news is, if you pick that up at 3 to 4 months or 3 to 6 months, you can do something about it. You can do something about it through things like an organisation called PIP UK, which is running in Northamptonshire, in Brighton, in Liverpool, and other places, psychotherapeutic support for parents who are challenged in their relationship with their baby. You can use a technique called video interaction guidance, which is extremely good research backing, to help parents who just need a little bit of nudging and help to improve the quality of their interaction. Or if you're dealing with parents who really have serious problems, you actually have here in London the very best, I believe, perinatal psychiatric support service in London, which is in the North East London Foundation Trust, run by Dr. Amanda Jones. It's a superb model which provides support to those parents who really are dealing with major challenges in their relationship with their babies. And it's a model I would like to see replicated across the whole of the UK. So we know what to do. We know the things to do. But the attention almost always is on picking up the pieces after things go wrong, not in stopping them from going wrong in the first place. I think everyone here probably had a grandmother. And I'm willing to bet that your grandmother knew that prevention is better than cure. Yet in public policy, we don't do that. That's what we should be doing.
Thank you.
Yeah. I mean, I do have some specific questions, but if I could come to you, Dr. Nettle.
Yes, well,
this is also my main question about the Mayor's Healthy Earlier program, improving child health, reducing inequalities, and also your views about targeting childcare settings.
Well, I'll come to the second question first, because as I understand it, that seems to be the focus of the programme, but I may have misunderstood it. So I'm going to make a declaration of interest here. I'm married to an early years teacher who is an outstanding early years teacher and who just retired from being such an early years teacher in something that sounds quite like what you have in mind for these hubs. So, and she may be watching. High quality early childcare settings, we know there is evidence that they can improve outcomes for children. James Heckman in the United States keeps putting out lots of studies and graphics to demonstrate that sort of thing. So if the proposed hubs are able to drive up the consistency of standards in childcare settings across London, then I think that's a great move. However, would it be, and I'm not wanting to actually put this in a kind of either-or kind of mentality, but all my colleagues around here, and I don't think I've barely met any of them, some of them I know of, but you know, we're all saying the same thing actually, is that is that most children are not accessing those kind of services on for many hours until they're probably getting to around 2. So in terms of wanting to make a difference to outcomes, it's actually before that is key. And so the opportunity to for every child to be assessed in the context of their family and home context, so that these kind of the quality of relationships can be observed and a discussion can be had about that, and those parents can be supported. Then an absolutely crucial point of connection in terms of what George has just been talking about is that you can search for health needs. That's one of the principles of health visiting. We have 4 principles. The search for health visiting. The next one is the stimulation of the awareness of health needs. So that mother, that father comes to a better understanding of the needs of their child, their infant, their own needs as a parent, and how they can fulfill them. And then it's the facilitation of health-enhancing activities. What can they do about it? And maybe they need access to some of the world-class services that you have here in London. But how are they going to get there if no one has sought out those health needs, if no one has recognised them in the first place, or if there's no one to refer them to? Now, there can be many places in which they're located. Some of them can be co-located in children's centre hubs or whatever, and that's great in terms of offering a range of services. Some of them are going to be more specialist referral centres. But there has to be a clear line of an assessment and pathways that lead there, that are really organised around the child and the family, not around the service provider.
If I could ask you to be as brief as possible, bearing in mind that we need to finish the meeting by 5 and still lots of questions to come up. Again, to all of you, to what extent do you think this program might be too little in terms of scale or too late in terms of intervening at the right time? I think some answers may already have touched on the questions I'm about to ask, but I think we just be very brief.
Yes, I mean, I'm aware that we could easily repeat ourselves because, you know, some of the same things apply. So I think certainly too late. I mean, I think what we're all saying, and I would say very strongly, is that we need to get in there way before most families are interacting with childcare, and need to really think about the key milestones in a young child's life. So pregnancy, the early weeks, those opportunities that we've talked about for parent-child bonding, you know, starting solids. All of these, you know, absolutely crucial things happen well before most children would be interacting, or families would be interacting with childcare settings. So I think there is a real risk that it's too late. And we're going to talk about the first 1,000 days in the next set of questions. So I think there's things to be said there that really apply to why this is too late. So I mean, I'll stop there, and I think we'll pick up some of this in the set of questions on the first 1,000 days.
I'd agree with what Kim has said.
Yeah, I echo the same.
I agree. I think we'll be missing
You agree
lots
in
of
reducing
children's
repetition.
families there.
Too late.
There is a point that, to me, encapsulates this. The home is the only childcare setting that is not inspected by Ofsted. I'm not saying that it should be. I'm not making that point. But actually, that is the most powerful and childcare setting. And it's the one that we should be focusing on. Not at the exclusion of high-quality childcare, but it is absolutely crucial.
I've listened to what you say, and I've heard a lot of this when I used to go to police training many years ago, and they were saying that the problems they have, and children that grow up in crime very often had no visual interaction with their parents. They never looked at them, and etc. So obviously we've been aware of this for many years. Do you think? I mean, we have to be honest with ourselves and look at the cost implications of all of what you're saying. Whilst what you're saying is completely correct, we have to look at that. Do you think there's room for thinking that we should take it back into proper education? Because the number of when people have children, they have got absolutely no idea at all, and they don't know that by looking at their child and giving them eye contact, etc., etc., it goes on and on. They're not taught that at school. They're not brought up with that. Now, if you've got a parent that does that, then the mother will teach her daughter-in-law, whatever's the relationship. But if you don't, do you think there's a way of combating this if we look to some sort of education much earlier, as you were saying? Because with the best will in the world, I can't ever see that we will be, as a society, will be able to afford all the things that we should be putting in place. What's your thoughts on that?
Shall I start? I think pregnancy is the time for that. I mean, there's an awful lot of thinking happened about how do we, we talk about the preconception period. It's actually really hard to get those people. I'm not convinced that doing it in school is going to make a lot of difference, because it's too far ahead. I think pregnancy...
The argument being that it should be done in the schools before they become parents.
Yes, I mean, I think, I don't think that is going to have enough impact. It's not what hopefully is on most 15-year-olds' minds at that point. And I think there's a lot to do about relationship skills that can happen in schools that all sort of impact on the kind of parent you become. But I think pregnancy is the opportunity to really help the parents to think about what sort of parents do they want to be. An awful lot of antenatal programs focus on labour and not enough, I don't think, about what sort of environment do you want your child to be born into? How are you going to get your lifestyle ready? A lot of parents spend an enormous amount of attention on this sort of nesting, preparing the room and getting all the equipment. But it's like, what sort of lifestyle do you want to be living, to model to your child? And what does your child need from you in the first few days, the first few weeks? And I think that's where that's where I would see we've got some traction, because parents, the vast majority of parents and parents-to-be want to do their very best for their children, and I think we can harness that in pregnancy. I think somebody said already, it's a time of excitement, hope, it's a new start. And I think that's where we could help parents to think about the period after birth rather than just on preparing for labour.
The Healthy Child Programme, which is the very, very well-established national child public health programme in the UK. In England, it includes 5 mandated points of assessment, but it's not just about assessment, it's also about an opportunity to explore needs and to promote and support health and life and lifestyle choices. And the first of those is in the antenatal period. And it's led by health visitors for under 5s. There's a similar programme led by school nurses for the school-age population. So that's one of my colleagues referred to the term transition to parenthood. It's an enormously sort of multifaceted experience becoming a parent, and so that is mandated as an opportunity to explore that, focusing not just on safe birth, although that is absolutely crucial. So the World Health Organization talks about three stages in child health: survive, thrive, and transform. And I think we're about all of those here today. So first of all, you need to survive childbirth. But then, having survived it, what do you need to thrive? And so actually that the teachable moment, the kind of the window of opportunity is, I think, there's a lot more evidence around this now, is within pregnancy, but to explore beyond just the immediacy of childbirth, as to what does it mean to become a parent. So what are, I was wondering where George was going when he says we've all had a grandparent. So there's grandparents are sometimes, this is what George was doing, but sometimes are sort of hailed as being sort of gold halo garlanded individuals.
We are.
Yeah, well, I'm a grandparent, and I am, of course, but not all of us are actually, So actually looking at where you come from and where you're aiming to go to, and having those conversations. Usually, preferably in a domestic setting, it's a great opportunity. So then, when the health visitor follows up at that, at the new birth visit between the 10th and 14th day, then that's the opportunity to take that up forward. So, what's the actual experience like? And then, preferably, then also at 6 to 8 weeks and 3 to 4 months. Actually, we're not talking about high-cost, high-tech interventions here. It's nothing to be frightened of. It's just routine service, actually. But the problem with it is that it hasn't been...
It may be on, forgive me for interrupting, it may be on your average family, but when you've got a family that's got lots of different stresses around it and difficult to get hold of and maybe might not want to see anybody in authority for difficult reasons, then you are looking at a different cost implication. And that's just why I intervened, just to say, is there room for looking at it before you get to that stage? Because when a mother's got a brand new baby, sometimes it's also overwhelming.
Absolutely.
That they can't take in what you're saying. That is why I was saying, is there room for looking at it before?
I think you're absolutely right about teenagers. What teenagers need is support around relationships, because this is all about relationships. This is about the relationship with your baby, the relationship with your partner, the relationship with professionals. And actually, I think what teenagers do need is that support about what is a healthy relationship and how you can develop healthy relationships, because I think that is just so key, thinking about domestic abuse and domestic violence and young teenagers. And we hear in the media every day about the pressures on young people and Facebook and sexting and all of that's out there now, and the pressure on them. And I think it's a key time where I think we can make a difference in terms of thinking about how they do their expectation of what a relationship is and how it should be for them.
I'm delighted to be able to relieve the boredom of the Health Committee by actually introducing a note of disagreement among the panel members, because I disagree that it would not be a good idea. I think it would be a good idea to have parent preparation for children in school. And I speak with some experience on this matter. 2 years ago, WAVE was commissioned by the Scottish Government to create a parenting preparation programme for 14 to 16-year-olds in not only Scottish schools, but also young offenders institutes and youth clubs and other such areas where parenting might be taught to children of that age. We consulted very widely with schools and children in putting that together. It was, and you're quite right, the points about relationships are right, because we called it the Parenting and Relationships Education Programme, or PrEP. And children were very interested in the issue of parenting. It wasn't our finding that they did not find that of interest or it was too far in the future. They were very interested in learning about it and knowing more about it, and very enthusiastic about the programme, as were many school head teachers and others who've picked that up and adopted it. I think there are many things which are very easy to teach. That, I've got 3 children, 7 grandchildren, but nobody ever taught me. I wish they had. You've mentioned this point about looking at a child, about responding in a responsive, attuned manner to a child, even just understanding the extent to which a baby's brain develops in its first 3 years of life, which is amazing to know. All of these are things that I think could potentially be of value for children just to know, and to know that when they begin to become parents, it isn't a question of sticking the baby in front of a television with a dummy in its mouth and waiting till it gets to 12 months of age when it begins to speak. That from the very beginning of life, babies are learning about the world around them as a result of the direct experience that they're having, and that parents can have a huge impact, for good or not for good, on that. So I do agree that pregnancy is a prime teachable moment. And I do agree that we should be changing the balance from talking just about the physical act of birth to preparing for the social and emotional development of the child and the parenting issues. But I also agree with Susan that we could, with great benefit, teach children in school about parenting.
Thank you. Okay. You mentioned you wanted to make progress in your question.
Yeah, well, if I could ask, again, at the risk of repeating yourself, I don't know that Mr. Hosking and Dr. Nettleton, you already touched upon this, but could I ask you to give 1 or 2 examples of best practice that the Mayor should be looking at in terms of developing this program?
I would highlight Amsterdam. The organisation I lead, Henry, has been working with the Healthy Weight Programme in Amsterdam, which really I think is a great example of the benefits of political leadership and having a 20-year strategy, thinking about the different ways that a healthy choice can be the easy choice, and really bringing together environmental changes with family level support, and bringing together all the professionals from different agencies and getting them lined up behind a common goal, and then really driving that forward and having very structured monitoring, learning, adapting, so that there's a real sense of continuous learning and improvement.
So I think looking at the Getting It Right for Every Child programme that's based up in Scotland, so the principles and values in that would be a helpful start to think about how that could be structured and framed.
Big Lottery's Better Start programme.
Big Lottery?
Better Start.
Better Start.
Which is focusing on prevention and strategic joined up working and systemic change.
I think there's just so many tools out there, quite frankly, and I think part of the issue is that everywhere uses something slightly different, and it's about that offer. I mean, you've talked about Solihull, we've talked about the Basildon. There are just so many tools out there. I mean, one of the tools that we use is the promotional guide tool, for example, so we use that antenatally, but there are just so many tools out there, and I think there just needs to be a bit more consistency, because families in one area will be exposed to one particular tool in another area. So I think it's thinking, I know other, Scotland, Wales, Northern Ireland, they have I think it's fair to say they probably have a much more joined up approach in terms of thinking about what is used and what's offered. I think it's something to think about.
I'd like to mention a Spanish program called Parent-Child Psychological Support, or PCPS for short. This is a program that begins when a child is 3 months of age and runs until it is 18 months of age. It involves a health centre or children's centre or family centre where the children are brought in to meet health professionals, typically health visitors, but also other health professionals. And they are assessed on a 3-monthly basis on the quality of interaction taking place between the mother and child. There is speech and language support provided to the parents throughout that period from 3 months to 18 months. And where there are issues in the interaction of the child and the parent, then the parent is signposted to support services. I'm sorry to use a technical term for anyone perhaps watching on television who's not familiar with attachment, but secure attachment, which typically is found in 60% of children, is a pretty good indicator of a child who is going to go on to have a good life with good relationships and good outcomes. in the PCPS programme in both Spain, and they replicated the programme in Dublin in Ireland, they were able to increase levels of secure attachment from about 60% to about 80% in a very deprived population. That's actually a very striking achievement. Levels of disorganized attachment, which are the worst form of attachment you can have, which normally are at 15% of a population, and in deprived populations can be anything from 24 up to 40%, they in Dublin reduced below 10%. i.e. they got a better result in a deprived population than other areas are getting from non-deprived populations. We are currently looking in the project WAVE is running in Northern Ireland, in Londonderry or Derry in Northern Ireland, at implementing PCPS there. I think it'd be a very worthwhile programme for London to look at.
Yeah, I just echo with Scotland, the growing up, the getting it right for every child. And Scotland has committed itself to an enhanced health visiting programme, which is based on the on a strong evidence base. So I'd commend the Scottish Enhanced Health Visiting Programme, and Wales, following in a similar line. A particularly distinctive thing to look at Wales is their emphasis on family resilience, which might be worthwhile looking at. Assessing and supporting family resilience.
Can I take up a point that isn't on the agenda, but it's one Susan has made that I think is very important, which is, can we afford to do the things that we're talking about? And I'm going to again be controversial, Susan, and say the answer is yes. And I say this based on the fact that there are ways of approaching public services that have been shown to produce very major savings in cost, and which, if introduced across London, would unlock the money that would enable us to invest in prevention in the early years. I'm just going to give you one example. Torfaen in South Wales, which is an area just to the east of Cardiff, implemented this approach. It's known as the Vanguard approach, and some of you will have heard of it. They implemented this approach to their health services, and what they found was, after 6 months, they carried out a review of what it would have cost carrying out the standard approach of delivering services, and the answer was £104,000 it would have cost. They looked at what it cost applying their method, and the answer was £29,000. Now, I'm not saying that scale of saving can be achieved, but Vanguard have achieved that kind of saving in, for example, Stoke-on-Trent. There's a whole book being written about it, and in other areas. There are ways that we could operate our public services more effectively that would unlock the money for investment in prevention.
Thank you. Thank you. Thank you. We're going to come to looking at the first 1,000 days, and I think we covered some of the stuff material already. So I'm going to be. I'll try to condense my questioning. I just want to know, what are the main risks in the first 1,000 days to the child? In the first, and that's 1,000 days begins from the time of gestation, I think includes gestation or conception, right to the second birthday. So let's start from you, Robert, this time, because to bring some change into, and give Kim some time to reflect on things.
Well, I really do feel sort of under some pressure sitting next to George as being the champion of the 1001 critical days document, Conception to Age 2, that just from WAVE that brought together so much of the evidence around that. So I mean, others will fill in some more detail, but I think that first of all, I'd use those two words, surviving and thriving. It's the most vulnerable time, both in the womb and in birth. We haven't really talked about safeguarding or child protection, but if you're going to be murdered, you know, the chances of being murdered are highest when you're under the age of 1, and where it's going to happen, it's probably going to be at home. You know, so we have a lot of concern in the press about knife crime and on the streets, and particularly in London, and that is a real issue. but you know, that is, so it's surviving is absolutely key. To have a mother that is well nourished and that is receiving regular antenatal care, and that is...
Sorry, can I just interrupt you there, because it was such an astonishing statistic that you just gave us, and you're saying that you're more likely to be murdered under the age of 1 than any other time during your life. Is that correct?
That's correct, yes.
Yeah, so it is, it's not an obscure statistic, it's very, very well known.
Clearly not very well.
Not very well.
We've just
You
proved
said you have
that.
2, haven't you?
Yeah.
Never.
So, yeah. So it's a very vulnerable time. But it's also a very powerful time in terms of future outcomes, as has already been said. So, it's very, I think, as we go down from, as we move towards the beginning of life, separating out our mind, body, brain, all the different components of what it is to be a human being becomes more and more impossible to do. So all the threads are really connected together. So this is where, you know, the nurture and nature and all of those things really work together in terms of producing those outcomes. And then the next thing I think to be really emphasized is that how is this child received into the world? What's the physical environment? What's the social environment? What's the emotional environment? So there's an awful lot of science around this, but actually it doesn't need to be expressed very scientifically. I've had the joy of teaching in this area recently, but to health visitor students and so on. But it was really brought home to me, so in a very personal way, by my granddaughter's first school report. Okay, so she came. It said on her school report, she talks a lot. She talks a lot about Beatrice. Okay, so about her sister. Okay, so what that teacher hadn't realised was that sister hadn't yet been born. So that second little girl was already had a place and a meaning and within that family unit. Now that's not to say everyone it's not to say it's a perfect scenario. Everyone finds having the adventure of parenthood pretty challenging. But it's about, what's the environment that you've been born into. Now, there's a whole spectrum that goes from that to the kind of adverse childhood experiences. That's, that can sound a bit clinical, but it's about a violent, aggressive, or maybe just an indifferent environment where basic needs are not met. And I think that's what's so crucial around those first 2,000 days, where all the pathways are led. So brain development is something, attachment theory is not new, but the neuroscience surrounding it, as there's a lot more understanding of the neuroscience that helps to explain why the formation of those key relationships and the interaction between them, why it's so important in that it structures the architecture of the brain in ways that are protective for future social and emotional developments, self-regulation and executive function are the technical terms that are used. Now, you might say, well, that's only one little corner of health. What about, say, things like dental health? Okay, we haven't mentioned that.
We were going to.
Yeah, but but actually, it is a bit of like a key to unlock so many other things. Because if you're attending to the infant in a way that is responsive to what their needs are, and if you as a parent have the capacity to do that, then you have the space to to meet their needs. So if you give them some information about, from wherever it comes, about, say, dental health and sugary drinks, then you'll make use of that information if you're in that parenting relationship. But if you're not, if you're preoccupied by your own depression, your own anxiety issues, or about whether or not there's something violent going on the landing outside, then that doesn't happen. We do need consistent messaging that goes out around things like oral health and diet and nutrition, but it's also the capacity to make use of that information. I don't care where that information comes from. In a way, I had a wake-up call as a health visitor, as a young health visitor, a very long time ago, when I was told very assertively by a mother that Esther Ranson was saying that Ribena was a bad thing. So she took far more notice of Esther Ranson, who was then a public figure in the media on health issues. Now, this isn't to decry the value of Henry programs, it's great. But actually, that's the social world in which we live. Parents need to have the capacity to make use of that information. And the great things about Henry programs is that it's not just about information, it's so much more than. It's about the whole package. Because if we don't set the direction right in the first 2,000 days, we really are trying to claw things back by the time children are accessing nursery or into school.
Fiona, did you want to ask your dental question at this stage?
I did, yeah. I think we picked up from the briefing we were given as the committee on what I thought was quite a horrifying stat, that only 19% of children go to dentists before the age of 3. We just really wanted feedback from members of the panel as to why this wasn't being pushed by professionals who were coming in contact with parents, albeit obviously it's not necessarily something people would have the answer to, but sort of why on earth are we only getting less than 1 in 5 children to dentists? Because I mean it seems to be quite an important thing for parents to prioritise, particularly given it's free.
The majority of parents in London don't see a health visitor after the baby's 6 to 8 weeks old. Is it not unsurprising that we're not picking up and dealing with issues like that?
But one of the in terms of the mandated points of contact, we have a contact at around about 12 months and at 2 years, and certainly where I work, it is part of our protocol that we do talk about dental care. Lots of parents don't think you need to clean babies' teeth when they first come through, so there is an education that's needed, and again that's something that we need to draw back and actually prepare parents for that. So in terms of thinking about when they're seen at 3 to 4 months, if they are seen, actually preparing them and getting them to think that through, that actually when child's teeth does come through, and thinking about, for example, what they, in terms of using dummies and in terms of what they put in bottles and just offering milk and water and not offering juices, for example, and the dangers that juices can do to teeth, to emerging teeth, and also, in terms of getting children onto cups, all that preventative work. But it is a case of you need to see parents to get that message across. So we absolutely do promote dental and dentists, and certainly whenever we see children at 2, we're asking, have they already been to the dentist? And
do you also ask whether they're actually registered with a dentist? Because obviously yes. the mother would be entitled to free dental care as well. So does this mean that pregnant women are also not going to the dentist then? If we've got
should be. They're certainly. Again, it's something that we would expect midwives and certainly health visitors seeing them in the antenatal period to talk to them about their own dental care, because it is a time when they can get free dental care.
Funnily enough, I happened to participate in the Child Oral Health Improvement Programme Board yesterday with NHS England and Public Health England, among other key partners. And there were quite a few presentations which spoke about the fact that the first points of contact for parents were community pharmacies and GPs because of trust, issues with being able to actually get referrals and register with new dentists was an issue. There was often accessing of over-the-counter medications at that point, and not realising when there's a toothache you need to go and see your dentist, but also exploring the fact that just giving someone a leaflet is not going to be a useful way to get the messaging across. So I'm sure that that's something I could go back to them and try and get you a bit more information if that might be useful for the committee.
Be interesting.
Yeah, it'd be useful,
Thank
yes,
you.
thank you.
Could I just say a little bit about the oral health service that Henry runs in Waltham Forest, which I think is a really good example of practical proactive steps that can be taken to do something about this, because I mean, you know, what's already been said, it is our experience too that parents often don't think that baby teeth need a dentist. And so we're working with local dentists and doing drop-in sessions within children's centres so that parents have an opportunity to see a dentist, not by having to find a dentist and go to one, but that the dentist comes into the children's centre, and we take the bookings. We advertise those sessions, we take the bookings. The take-up is extraordinary. I mean, we often have 70 parents through those sessions in the course of a day. So it really does seem that parents are motivated to access a dentist. The advantage of this approach is that then they can be signed up to the dentist there and then. We, as well as having their teeth checked, we're also doing fluoridation, fluoride varnishing within the children's centre setting. So it's very much a sort of stepping stone between a known early years setting and the dentist. And what we find is also very effective in increasing access to dental services to, again, be very proactive, to go along to you and your new baby groups, stay and play sessions in children's centres, and give parents lists of local dentists that are accepting new patients, and do that sort of legwork so that it's not about, oh, your child should see a dentist, and then expecting parents to do that. But yeah, I would say that actually having that proactive approach of inviting parents to bring their children to see a dentist in a children's centre has been phenomenally successful.
Can I just add as well that so we are working with our paediatricians to make sure that if any child that they see, that it's included in that child health assessment. And the other thing that we would like to see is that when babies' teeth start emerging, when they're erupting when they're a year old, for that to be recorded in their personal child health record, as alongside all the immunisations and all the other things that are recorded in that around weight management. The other thing that we would definitely like to see is some real consideration taken up about fluoridation of public health services, public water services as well. So we are hosting a session later on this month around oral health with a range of health professionals. So it's not just around kind of health visitors or health professionals as a whole need to be kind of aware of this, because it's the biggest single reason why children are admitted to hospital and receive a general anaesthetic for tooth extractions, and it's entirely preventable. So there are a few things alongside the other things that people have already said that could be done to help the situation.
Andrew?
Mr. Hosking, many Londoners live in poor quality housing. Many families are being brought up in poor quality housing, and it's estimated that well over 300,000 live in overcrowded conditions. What effect does overcrowding have on early years development?
Overcrowding is clearly, you don't need me to tell you, a very powerful and negative effect on people's health and general quality of life. We're just about to produce a report, which is a 3-year study, looking at children between the age of 2 and 18. and understanding why children slide into lives of severe and multiple disadvantage, by which we mean some combination of homelessness, mental health problems, addiction, criminality, etc. And we've also set out what we believe are solutions to this process. And the first thing that we would put on the solution is to provide people with good housing. It's the very first step in rescuing people whose lives are spiraling downwards into conditions where they end up on the streets or in our hospitals with chronic mental health problems, etc. So I certainly strongly believe that that is something that if we can do something to improve in London, and I believe the Mayor is very committed to that, that would be a very positive thing to take place.
Can I say the jury's out on whether or not the Mayor is committed to that? There's a 250,000 words in the draft London plan, and it only mentions overcrowding once. And he's also dropped all the targets that his predecessor had for building family-sized homes. So we're quite concerned, some of us are quite concerned that this very important social issue is actually being dropped from the agenda in London. But I'm very grateful for your words. I very much appreciate that.
Can I just say, having been in lots of overcrowded homes, it is devastating for the families and in terms of their child's development. I've been in many homes where they can't put their baby on the floor because there's nowhere to put the baby. So that has an impact on the baby's physical development in terms of not having the opportunity to learn how to roll over, learn to crawl, all those really early skills that are really important. I've been in homes where they don't have the room to put a cot up. So that baby goes from a Moses basket into bed sharing, and that puts the baby at risk of cot death. So I think, it is absolutely devastating, and for those parents living in those situations where they don't have room to put things away. They have the stacks of clothes and bags because they just don't have room at all. It is and to go back into that environment day after day, or just to have the energy to get up and go out, in terms of their mental health, and in terms of the impact on those children. Some of the conditions that I've gone into are frankly appalling. When you sit there and parents tell you about the rats that run out while they're looking after their children, I mean, it is really quite shocking. And I think that has a real impact on the workers that work with families. And I think that's one of the things about London is you get a real churn of staff because there's only so much you can take.
Yes.
When you're going in, and that's visit after visit after visit, there's no variation. You go from one to another. And your thresholds, and I think that often is what happens with social care as well, their thresholds just get higher and higher because you've been in one home and you think, you go into another and you think, well, it's not as bad as the one that I've been into, so maybe it's okay. So I think it just has a devastating effect on people.
It must have. It must have.
We're all going to go home to our nice homes.
That's very powerful.
Thank you. Can we just come back to the first 1,000 days again, right? And anyone can come in. I mean, I think we don't need to. Everyone doesn't need to answer every single question, right? So, but the question I really want to ask is to what extent is sport available to everyone in London in the 1,000 days, and which particular groups are finding it difficult to access the help they need in the first 1,000 days of a child's life? Which particular groups are finding it difficult to access the service, and is the service available to support them?
Well, I think if we look at the National Maternity Review, it highlighted that the whole system needs to change to respond better so that women get choice, continuity of care and access to mental health support and useful information so that they can make better choices. From Best Beginnings work, young mums are a group who would struggle to access support, although Family Nurse Partnership are really great at working with that group, and we only hear great things. BME communities, and of course new migrant communities who might not have any idea how our health system works here. And so, groups will struggle to access support or information if they have no idea what's available and are not told that they don't know that the support's there as well. So something to bear in mind.
Okay, thank you.
I think that we as an institute surveyed who were health visitors working with and for what kind of proportion of their time. We've sort of extracted the London data about the types of problems that health visitors in London are working with. And I mean, the answer is that they are working with those who are the most vulnerable in society. Now, bear in mind that the role of the health visitor is not is intended to be a service that's provided for all, just like, say, a school is for all children. So it's, in that sense, it's an inclusive service. So put in that context, I think it's quite striking that 83% were working with postnatal depression or mental health problems, often, very often, or all of the time, within their caseloads. 86% were working with families where there's a child protection plan at that level as well. 71% where there is families that need interpreters. 61% where there's working with looked after children. 60% where there are drug and alcohol problems. 60% where there are refugees, asylum seekers, and similarly where there are homeless families. So health visitors are reaching out to some of the most vulnerable groups and engaging with them. The reason why they're finding them is because health visitors visit every family. Otherwise, many of those would not be picked up. So everyone has a health visitor. So you don't have a health visitor because you have a problem. But actually, this is where I think there's a particular concern about when George was saying that a lot of families aren't seeing a health visitor beyond the 6 to 8 week check. There are other mandated checks as well, but as Geraldine referred to. I think there's another concern about there's the families with the most extreme needs, and then there's those families with quite substantial and children with quite substantial and difficult needs who are just under that radar. And I think that point about thresholds that Geraldine was making just now helps to kind of highlight that. Or I use the metaphor of the iceberg. You know, so then if we just focus on let's say that the tip of the iceberg represents children who are on a child protection plan. Well, there's a lot of children who are just below that level. And I think that for me is a real area of concern. Now, I'm not saying that out of knowledge of London from a specific point of view, but in looking at, well, I suppose I am, because if I look at the survey data, that health visitors are struggling to meet their mandatory requirements to deliver on only 5 mandated contacts, which should be assessments and action that follows from those assessments, crucially, which is often forgotten. They're struggling to do that, but they're also saying that they're overwhelmed with more and more child protection and child protection related work. So they're kind of getting caught between a rock and a hard place. So but I don't want to talk about health visitors, I want to talk about families. So I think there is, different people talk about it in different ways. Politicians have talked about just about managing or squeeze middle, but there are a lot of families under a lot of pressure and children under a lot of pressure trying to juggle the issues around employment and housing and so on, and social isolation and those kind of ACEs that George has been talking about. So I think there really is that zone that will only be reached if we have a proactive outreach kind of pattern of services, not one that is focused around come to me, come to a children's care setting or a children's centre, good though those are.
Just a point to make. Robert mentioned 5 mandated health visits by the health visitor. In the new Scottish health visiting plan, there are 11 mandated visits by health visitors. Yeah. So important do they consider it to give the right support to parents in the first 2 years of life. Yeah.
And we're picking up evidence from our colleagues such as Geraldine. I'm not saying Geraldine, but service leads, that commissioners in London are now asking that some of those mandated visits be done on a targeted or selective basis. I think that should be challenged because mandated means mandated. Difficult for someone from a service provider to challenge that when they're in the process of tendering. So I've talked about the commissioning process before. I think this is something to really look out for. You know, we're not talking about a luxury service here. It's actually quite a minimal service compared to the rest of the UK. You know, England is falling behind the rest of the UK.
When these commissioning groups are wanted to reduce the saying for targeted groups, do they have evidence to back that argument up, or are they just coming up with this idea to save money?
I think it is to. I think it is to save money. Mm-hmm. There's some quite interesting evidence buried in a piece of work that Public Health England did. When the commissioning transferred to local authorities, the mandation of these 5 contacts, these 5 reviews, was in place, but for a time-limited period. And they undertook a consultation as to whether that mandation should be continued. I think that my understanding is that the preference was that it wouldn't be, but to give freedom to local commissioners to make their own mind about that. However, there was an overwhelming, from a whole variety of sources, support for the continuation of that mandation, so that very minimal level of child health surveillance and promotion should be maintained. Buried in that, there was evidence around commissioning intentions. This was at an early stage of the transfer of commissioning. So it was quite revealing that local authority commissioners were looking to the opportunity of having taken over that from the health service, from NHS England, to introduce more skill and grade mix, and to save on costs. We understand that there are cost pressures. And then, of course, at the same time, the relative protection around the NHS spending didn't apply to public health funding. And then there was an in-year reduction to the public health grant. So there's a bit of a perfect storm around children's public health level of funding, which I appreciate is the world that you as local authority individuals are dealing with.
Just one more last question before I hand you over to my colleague. The immunisation levels amongst children in London, we're told, is lower than the rest of the country. A, is this true? And B, if it is true, why London does worse than the rest of the country?
Can I defer to my London-based colleagues on immunisation?
Yeah.
I think possibly one of the factors is that there's a lot of churn in London. Yeah. Parents are moving, so it's very transient. So it's often quite difficult to track parents and to track children when they've moved. So I think that's probably a gap. So in terms of those children being offered and the uptake and signing on again with a new GP. So I suspect in other parts of the country, you have a much more stable population. I think part of the issue may be that we have quite an influx of children from abroad coming in different communities. Then they don't understand always, as being said before, about how our services work and what the offer is. So there's an education that's needed there. So I suspect that's the probably quite key areas. And also, if children aren't being seen at key times, I mean, one of our personal in our area, one of the reasons why we do our contact at 1. Other areas do it at 8 months, but we do it at 1 because we think it's key in terms of the MMR. So we want to promote that. So we've chosen to do our contact at 1 instead of earlier, so that actually that message can get across. In terms of the uptake of the preschool booster, that isn't until they're almost 3.5. If the last time they're seen by a health visitor or somebody in the skill mix team is at 2, they may well have forgotten about it, that they actually need to have that if they haven't been to the GP. I mean, it used to be, years ago, that reminders were sent out, but all that stopped. So it is very much down to the parents to actually go, you know, to be proactive and to go and to have those immunisations. And if they haven't had contact with a healthcare professional to say, oh, what's happening with the immunisations, are they up to date, have they had this, it's probably not going to be on their agenda.
And do you also think it might have anything to do with the social influence of that report that came out some time ago linking immunisations to autism?
Autism. I mean, that whole piece of research has been completely discredited.
I'm completely aware of that, but I'm just looking at it from a Facebook perspective and from conversations I hear with my girlfriends who have children. When we're talking in social settings, the conversations we're having are, is this safe? Is this the right thing for my child? And unfortunately, the understanding about the herd, the majority of people having immunisations, is not at the forefront of those social conversations. So I wonder what influence that would play as well in choice.
I think it probably has had some influence certainly in London, because I think there was an awful lot of hype in London at the time. I would hope that certainly from the health professionals' point of view that they're actually getting that across to parents and saying that that research has been discredited and there is no link with autism. But again, those are if those conversations are taking place.
I think we can't be complacent about that point though, because there was social media activity again last year where some of that evidence started to, or some of the research that was originally used was starting to be used again. And particularly in America, Donald Trump has said some very clear things about immunisation. So I don't think we can be complacent about giving those consistent messages about the importance of getting children immunised at the right time.
Thank you. Sue, over to you.
I think you've answered a lot of this, so if I just throw the questions out there, if you've got anything additional to add. What are the key ways in which health visitors support healthy early years? I think we've done a lot of it, but is there anything else? If there isn't, I mean, you've been so good with your answers. You've given us so many answers.
I mean, I think probably health visitors, as Robert was saying, in terms of baby brain development, I think we're much more attuned now, and we all that research, and I think parents are really keen to engage in that. You know, they're often very fascinated when we start to talk to them about that. So I think that's a really key message that we can get out there. I think in terms of health visiting is a universal service. It's a very unique service. We're very privileged that we do go into every single home. We do have that opportunity to assess the home environment. We look at something called the assessment triangle. So we think about child development. We think about, we're assessing the environment. We're assessing social impact, parenting skills. So it is very much a holistic assessment that we do. I think health visitors are particularly good in terms of observation and those nuances, and thinking about the reciprocity, the dance between the parent and the child. So I think health visitors are very, very skilled at doing those things and being able to pick up the risk factors and thinking about thresholds. If you go into every single home, you have a very clear definition of where there are risk factors.
And if you have concerns. There's no barrier to you passing that information on to other health colleagues, is there? I don't know where the lines are with confidentiality.
In terms of confidentiality, obviously we would always ask for consent in terms of making referrals. If it's a safeguarding issue, then consent can be overridden. So if we think a child is at risk and parents choose not to consent, we would still make that referral. I mean, the child's needs are always paramount, and they should always be at the centre of the work that we're doing, always.
So you don't find that there's a problem on a line there, which, you know, do I go this, you know, is it slightly safeguarding or not? Do you find that certainly if you've been doing it a good few years, you've got a more robust way of looking at it, but new people into the profession, are they happy within themselves to be referring, do you find?
We have robust in terms of child protection supervision. So we have child protection supervisors that staff can talk to. They have reflective supervision, they have clinical supervision. So those kind of issues would be discussed, and we would always encourage staff to go and talk to somebody about it. Always go, and if you've got gut feeling, always go with your gut feeling.
Gut feelings.
Gut feeling is hugely important, and go and talk to somebody about it. Always share. I always say that. Always share, even if you think, you know, often when I'm talking to parents, they'll say to me, I know this sounds like a silly question. And I say, no, it's not, it's never silly. And it's exactly the same with colleagues and professionals. It, you know, if you need to talk about something, you need to talk about it.
Okay, thank you. Has anybody else got anything on to add?
On that point, I think that practice and the system supporting practice have evolved tremendously over the last 20 years. So I think while it doesn't mean that it's not difficult and challenging, I think the knowledge, skill and supporting systems are much more in place than they were. I think a real concern, however, is that having done that, then what happens? So I think that the health visitors find that they're carrying higher and higher levels of risk within their caseloads, and finding that because of the pressures on children's social work teams in terms of what they will, what referrals they will accept and what they will take action on. So there is a consultation. Well, the consultation's just finished now on a revised version of Working Together to Safeguard Children. So there'll be the 2018 edition. And I did make, or we as an organisation made quite a number of points around thresholds. Actually, the Working Together in its revised form is moving away from the term threshold to criteria for action, which I think is could say it's a semantic difference, but I think actually it's a helpful one. It's not some kind of bureaucratic measure. It's about, you know, sometimes action needs to be taken. I think that there are other concerns around referring on to other what I might call care pathways that may or may not involve safeguarding, that are evolving in the context of what's called early help. You may have heard of this term, early help. Eileen Munro did excellent work reviewing child safeguarding a few years ago now, in the light of the Victoria Climpier case, and made many recommendations, and one was that there should be more emphasis on prevention and early intervention, and she coined the term early help, that help should be mobilised early, and I think the whole of our discussion would be supportive of that. Another key learning in her very thoughtful and well-respected report was that social workers and others were becoming fixated on the bureaucratic requirements of the safeguarding and child protection system, and losing their professional judgment, and not keeping their eyes on the child and more about the system.
Okay.
Unfortunately, I think that early help seems to be becoming now, rather than, is becoming bureaucratized at a local level, many health visitors are finding, so that it becomes, so in order to have an early help assessment, that parents need to give consent to an early health assessment. There's nothing wrong with early health assessment, and it's about enlisting the cooperation of the family in order that they might then access some other supportive services that are provided by a local authority. It particularly applies to local authority provided services. But if they may not be agreeable to an early help assessment, but they might be agreeable to the help that they could get, that would provide. So I just wanted to, this is coming through from our contact. I don't know if it's something that Geraldine recognises from the area where she works. It varies from one place to another. So I've seen it in some parts of London, I've seen some parts of Merseyside as well. So I think that's just something to be conscious of. You can refer, but what do you refer to? What happens next? There's no point in, if health visitors find, or indeed other workers, find that they're referring on for additional help and they're receiving a blockage, then there's always the worry that they'll begin to give up.
Okay, thank you. Can you just tell me who wrote that report?
Eileen Munro. Yeah.
Eileen Munro.
Eileen Munro, yes.
Okay.
Yeah, she's a professor of social work at London School of Economics.
Okay,
But
I'm sure we'll look
her
there.
background is in social work in the NSPCC.
Thank you. I'm mindful we've got to move on. One of the other questions, what impact has the transfer of health visiting services gone to services to local authorities had? I think we've covered that as well, haven't we? Has anybody got anything additional to put?
I'd just like to add that what it means in practice is often that there's changes of provider, and we rather than health visiting being a homogenous service delivered by NHS, and in some cases the contracts have now transferred to local authorities. We've got all these different providers, and as an organisation that has been working in close partnership with health visitors at local level for a number of years, we've noticed that the procurement changes of provider means that there is less investment in long-term training and workforce development and partnership building. So it is harder in areas where the health visiting service has been put out to tender, and a completely new provider like Virgin Care may have won the contract. There's a dislocation there of local partnerships, and particularly this investment in long-term training. So Henry, for instance, one of the ways in which we have been working with health visitors over the years is that we provide a 2-day training to health visitors to provide them with the skills, the approach, the confidence to tackle some of these very sensitive lifestyle health issues, and really build their confidence to work in partnership with families. Where we've got these different providers, there's much less interest in commissioning that kind of training.
Okay, thank you. That's very helpful.
It is quite dramatic, the impact of the transfer of commissioning. So the feedback from London health visitors was that 34% of them said that they had their employer had changed in the last year. Now, there'll be 2p and things like that, so it's not necessarily as that drastic, but it's pretty unsettling to staff that should happen. So 49% of health visitors have experienced restructuring of their service since local authorities took over commissioning, and they've experienced reduction in health visitors where they work, despite very high caseloads. And actually, George referred right at the beginning of our proceedings to the rising level of caseloads. So, what this also means is that in terms of what do families experience, it becomes very difficult when so many changes occur to offer continuity of care. So I was hearing, for example, from a colleague in one of the London boroughs about some very good care, so I don't want to be sort of talking about all the bad things all the time, so very effective pathways that they developed to services with the, is it the Evelina Children's Hospital, is that? Yeah, okay. But they were concerned that that with a change of provider, that those pathways might be broken. So there really is an issue around fragmentation that comes with, as well as disinvestment. The coalition government, you know, the can we afford it thing, the coalition government that came into place just at the time of the economic sort of catastrophe and austerity coming in, decided to increase the number of health visitors in England by 50% in only 4 years, which was an incredibly ambitious thing. It was achieved pretty much with an absolutely heroic effort. So that was an additional, in England, 4,200 health visitors in 4 years. Well, it was actually about 4,000. Data was collected assiduously during that time. Systematic data isn't collected now, but piecing it together, what it looks like in England, we have, since the transfer of commissioning, we have lost 2,000 health visitors. I just have to say, by anyone's reckoning, even if you think health visiting is not a great idea, that's a huge waste of public money. But also, in terms of the investment in the training, the workforce development, the upskilling that went with that. So it really is a very crucial time for health visiting, which is an incredibly valuable resource that's available to all children.
So I think we all understand that. It certainly is. I mean, the last question in this section is, what are your key areas of concern for this service for the future? But I think we've covered that. Obviously, training, changing and churn, and obviously
and any reduction in those mandated visits, because I would agree with what colleagues have said, that those are such a crucial opportunity to identify need early and intervene appropriately. So, I mean, we've said we would like more mandated visits, but I think a risk is that the 5 that are mandated at the moment could be further reduced.
Yes, at the very least, keep it at that, not increase it. Doesn't. Shall I go on to right, I'm going on to breastfeeding now, if I may. To what extent is London a breastfeeding-friendly city? Who would like to start?
I'll start if I can. I looked at this from the point of view of public space. Firstly, to start, I think it was only 2010, don't quote me on that, that it became a legal right to be able to breastfeed in public. So I think that's something to bear in mind. I think partly, yes, London is quite a breastfeeding-friendly city. You do have places that you can breastfeed in public, like parks and children's centres, libraries. There's lots of baby-friendly coffee shops around. But restaurants and public transport perhaps are not so accessible. There's less stigma in London than there are in other cities nationwide around breastfeeding, but some women are still made to feel ashamed and are not given the respect that they are due, even though it is their legal right.
Okay, I think that's it in a nutshell. Does anybody got anything else to? I mean, I'd agree with all of that. Anybody else? No? I mean, the next question in this section, what are the key challenges for London's parents in taking up and continuing breastfeeding?
I think one of the issues around breastfeeding is that now that women are discharged from hospital so incredibly early, so incredibly quickly, that often they're discharged and feeding absolutely isn't established. Yeah. You know, if you go home 6 hours after having your baby may well have only latched on once or twice. If you're a first-time mother, you're probably home certainly within 24 hours. And those early days in terms of actually mastering breastfeeding, because the reality is it's not that easy. For some it is. Some it's a bit like duck takes to water, but for some it's not. Some women really do. It is an art to learn how to breastfeed, and I can say that from personal experience. I really can. And I don't think the support is out there as much as maybe it has been in the past. I think the midwives don't visit as often as they used to. You know, they'll do a home visit once the woman is home, and then it will probably be the woman coming into the local children's centre or health centre on day 5 for the blood spot, and then again on day 10. So I don't think the women don't have the support that they need in terms of breastfeeding, I think. So I think it is a real challenge. I think we've got a lot better at not promoting formula milk. I think that was an issue in the past in terms of giving parents top-ups to go home with just in case you need it. So I think we've got much better at that. I think we really do need to think about advertising on television, you know, in terms of baby milk companies, and, you know, in general, that whole ethos about breast is best, and we should be promoting that. And it's not right for all parents, and we need to respect that. But so for some women, it is the right thing, and for other women, they will choose not to, and we absolutely need to support them. So we need to support them either way. If they want to breastfeed, they absolutely need 100% support to do it, because it can often be quite a tricky journey. And I don't think, and although there are areas that have got peer support, I think it is still an area that we really do need to work on in London.
Do you think there's anything?
Could I just pick up on that, because I think Henry is providing an infant feeding service in Waltham Forest as part of a commissioned service to really sort of tackle that gap. And so we have a team of paid peer supporters, and the feedback from parents about, you know, that service being available universally. I mean, as part of what we do, we contact all mothers within 48 hours of the birth, and what we know is that there's a huge drop-off in the first few days, and within the first 2 weeks. But from initiation, percentages are quite high. So it's those first few days which are absolutely crucial. And as Geraldine was saying, and I know as well from my own experience, it's such an intense time as a new parent, and that's when you need the support. So I mean, I would really highlight that as a very practical and fairly low cost service that can be provided, to have within each borough these paid peer supporters who are there in those first few days when there are difficulties, helping with latching on, helping with positioning, providing that emotional support, listening, debriefing the birth, all the things that can contribute to breastfeeding not becoming established or not continuing. We know from the feedback that we've had from parents that it's just been, you know, the difference between breastfeeding or not breastfeeding. And I think we just can't really make a difference to breastfeeding continuation rates without putting that support in and without making sure that parents do have access to that.
In the Netherlands, which has far better health outcomes for children than we do, they have a system which they call kramzorg, which is that a nurse spends a week with the mother at home, not 24 hours a day, but she spends time with the mother every day for 7 days after she returns home, making sure that she settles into looking after the baby, making sure that she's not distracted by the needs of looking after the family or looking after the home. Sometimes her role is actually to keep the other family members away from mother so that she can give her attention to the baby and provide the type of support that I think that you're talking about. It seems to work extremely well in the Netherlands.
I think there's also two groups where we know that the prevalence of breastfeeding is particularly low, and that's amongst young mothers and from particularly deprived and groups, from socio-economic deprived groups. So I think there needs to be support needs to be provided to every mother, but particularly targeted support to those two groups where we know the prevalence is particularly low.
Why do you think that is? Why would you say it was those two groups?
I'm thinking off the top of my head, and there probably needs to be more research into some of this, but it's just not. it's not encouraged, there's a lack of support. I mean, as Kim has already mentioned, the first few days are particularly important, and if you're feeling kind of stressed out and it's not seen as something that other members of your family have done, or your peer group, then it's not something that you're going to do yourself. So I think it's kind of like a bit of a domino effect. I think once it's seen to be more acceptable to do, and you see more people do it, more women doing it, then it will become more kind of socially acceptable, and more women will be encouraged to do it themselves. But it's making sure that support is there right at the start, and particularly at the 6-week point as well. So I think that's another point where we know that things, lots of women, they get to that point and then it just kind of drops off a bit of a cliff edge. But if you could get women past that 6-week point and up to 4 months, where babies do need to have, might need to be supplemented up to 6-month stage, then that's again another important, crucial point in that in the first year of life of a baby.
I think changing some of the messages as well, that helping parents see it as normal for it to be a bit of a struggle to begin with, that both the mother and the baby are learning, and knowing that in advance. So I think again this is where support in pregnancy and having the conversations in pregnancy is really important. That parents, or particularly new mothers, know that expect it to take a while, and not so that if they're still having a bit of a struggle after 3 or 4 days, that they don't at that point think, oh, it's not for me, I can't do it.
Goes back to early education again.
Absolutely, yes. It links with those earlier points that you raised about the education in the antenatal period, and also, and I hadn't heard of the example of parenting education in schools, but that sounds excellent. And I think that, any kind of parenting education package like that is about helping to shape expectations and attitudes towards what parenting involves. And I think it's in those particular groups where quite often the attitudes towards what breastfeeding is, and self-confidence about maybe stepping outside of your cultural norm may be quite low. So those attitudes and intentions are much more likely to be formed early on. It's quite easy to persuade somebody or to go along with putting the baby to the breast in the antenatal unit. It's a very controlled environment, but then going home is a different thing.
Interestingly, Family Nurse Partnership have very, very high rates of breastfeeding, successful breastfeeding. Family Nurse Partnership, who work with young teenage mothers. So these are women who are 19 or under with their first baby. And again, it's the support. They have the support network there. And if you're interested, if you Google breastfeeding rap on YouTube, a group of the breastfeeding rap. So it's a group of teenage mums from an area, Family Nurse Partnership, and they're actually rapping about breastfeeding, and we often show it to clients because it's really engaging, and just anybody you can breastfeed.
Way of talking about it.
I would also echo the comments that have already been made and say that I think the 2 key points are around relationships, so with breastfeeding peer support workers, and with the new mums group as a whole, the social support network, because who are the people who are having the most contact? Well, you might have a WhatsApp group with other new mums that you met in your antenatal classes, and you're going to be gathering and sharing info that way. So you're more likely to listen to them and have a closer relationship with them than you would have with your health professional. The second point around sharing information, this is the From Bump to Breastfeeding DVD. It follows 4 mums through their journey and all of the challenges that breastfeeding can give. I think the majority of new mums would have a big intention to give their children the best start in their life. But if you're experiencing pain when you're breastfeeding, both emotional and physical, then you might just give up or just feel guilty, or it might take days and days for your milk to come through, and you might just think that there's something wrong and your baby's starving, so you just got to go onto the formula. So relationship and having that time and space for the woman will enable her to overcome those challenges. But we found that this has been really useful. So
Okay.
I think that's just enveloping all these aspects of good practice is, I think, is the importance of all the professionals and agencies, and at whatever level, including peer and volunteer supporters, working together in a very consistent way, giving very consistent messaging, because it can be a bit bewildering that, and I would include general practitioners as well. They're sometimes the harder group to engage, actually, in terms of developing consistency of practice. So UNICEF baby-friendly standards is widely recognised as the kind of the gold standard, and that's really about everyone all coming together around a shared agenda and a shared set of standards as to the kind of knowledge and skills that we're using, and that's built into initial training of health visitors and midwives, increasingly so across the country.
Thank you. I'm mindful of the time. The last question, maybe, unless anybody's got something to say now, if you think about it, you could send in your answers. But the last question is, what can the Mayor do to support more people to take up and continue breastfeeding? If you've got something you think instantly you can do, tell us
EastEnders
now. Sorry?
Have EastEnders run a programme in which, or a series of programmes in which the value of breastfeeding is really brought across.
Yeah.
You've got a good point. You've got a good point.
Fiona, you want to come in?
I had 2 points on breastfeeding. One was sort of what makes breastfeeding friendly city, because I haven't had children, but I know from sort of talking to my friends and family that not all of them would see it as sort of breastfeeding friendly to be allowed to sort of breastfeed in the middle of a restaurant. They want the option if they wanted to, but they'd also want to have somewhere quiet if they want to go somewhere quiet that wasn't a toilet. And I think we've got to recognise that breastfeeding friendly does involve people being able to breastfeed in public, sort of in the middle of a public space. But actually, it also needs to make sure that we don't have a situation in which women who want a little bit more privacy don't end up sat in a toilet, which I think a lot of people do, and we've got to be honest about that. Yeah. And then the other thing is, to what extent, I thought Kim's example of what your project does is fantastic in terms of support. To what extent have existing or previous breastfeeding clinics being cut? Because I thought there was an example of one in Southwark that was cut due to sort of cuts within the NHS. And to what extent have services that supported women in breastfeeding sort of vanished? Because I mean, are we talking about sort of trying to stop things being cut, as well as sort of looking at new initiatives that should be encouraged to come forward? Which is quite a long question. Sorry.
Just while it's fresh in my mind, I think traditionally there's been a lot of reliance on volunteer breastfeeding counsellors giving up their time in local communities, and often very passionate, very helpful, very supportive. Their reach tends to be quite limited in terms of the demographics of people who are able, motivated, confident enough to access that service. So I think, what is a particularly important feature about the service that we've been commissioned to deliver in Waltham Forest is that it's paid peer supporters. Yeah. So that service is there as a matter of right. It's automatic. It's available to everybody. And I don't think that Waltham Forest are alone in starting to commission services like that. Increasingly, paid peer support is recognised as a way of making it as cost effective as possible. That we don't necessarily. I mean, it also ties in with community midwife visits being scaled back over the last few years, but thinking about, well, there's other ways that support. You know, we no longer are in the days of a daily midwife visit for the first 10 days, where those sort of breastfeeding issues would have been picked up and supported. But we can still find you know, more cost-effective ways of that support being there for parents at the moment of need. I think
it's also showing that you value them, don't you?
Yeah.
You know, if you're paying them rather than them being volunteers, because we have a breastfeeding support service, we have peer supporters, but they're volunteers, and the people that are paid are the people that manage the service. So I think it's about valuing that actually women do need that service, and rather than, and it's again, it's very piecemeal, isn't it? What will happen in one area won't happen in another, and I think that's a real sense about London. Everywhere's slightly different, different offer.
Could I just ask a question about the programme? I just wondered whether it was representative of the communities that live in Waltham Forest, because I actually live in Waltham Forest, so I know how mixed the communities are. And so was that anything that you found?
What, in terms of the staff team that's providing the service? Yes, it is a mixed. It is a mixed team.
And do you think that that's been something that's become part of the success of the programme as well? Is that mums can come and talk to someone from their own community, perhaps in their own language about this?
Carly, maybe I suggest that you have this conversation afterwards, right?
Sure.
Because we are very keen to press on, right? And I'm sure your questions are very important. They'll be answered. But if I could just.
Yeah, that's fine. So it was
Andrew?
my fault for no more questions.
Let's talk about school readiness. What does that mean? And what are the challenges for London's children?
Yeah, I'd like to open on this if I may. We've had Professor James Heckman mentioned earlier. He's a Nobel Prize-winning economist who's done a lot of study of the early years. He's identified that there are two types of skills that children need to succeed. There are what we might call the hard skills, reading, writing, and arithmetic. And there are what he calls the soft skills. And the soft skills are things like emotional self-regulation, perseverance, eagerness to learn, self-motivation. And these soft skills are essentially created in the home in the first 18 months to 2 years of a child's life. Heckman has identified that success is more dependent on a child having both soft skills and hard skills than where we tend to put all of our attention, which is the hard skills alone. There have been other studies carried out, I think one in London, which I can't remember whether it was the LSE or actually the GLA itself, but I've got the reference back in the office, which identified that having these soft skills is actually far more important than IQ in determining whether a child succeeds at school or not. Now, we have already established there are some grandparents in the room, probably rather more parents in the room. So those of us who have been parents or grandparents will know that the natural way for children is to be eager to learn. They're just, I mean, how many of us have been driven mad by children saying, why? They just need to want, they are sponges for new knowledge and new information all the time. When children have that attitude to life, they are naturally school ready because they arrive at school eager to learn, eager to find new things, eager to engage in the process of finding out whatever it is that the teacher is leading them to explore. But far too many children do not arrive with that kind of attitude to life. They are fearful, they are worried about other people's opinions of them, they have had a life in which their sense of self-worth has already been destroyed because they've been told so many times that they're useless or their parent wishes they'd never been born or things like this. Or they simply have the fear that comes from years of physical abuse. Or they have the complete lack of any kind of interest in the world that comes from total neglect. The failure to develop the neurons in their brain to fire in the way that a naturally healthy child does. research both at the University of Mannheim in Germany and at universities of Cambridge and Oxford have identified that the differences in children's ability to develop and learn can be identified as early as 3 months of age, and that the differences simply grow larger and larger from 3 months and 12 months of age right through to the school years, and it's been measured in research studies up to age 11. So whether children are school ready or not is determined to a very significant extent by the nature and the experience that they have inside the parental home, or if they're in a care home, inside the care home, in that first 2 years of life. So if we want to change school readiness in London, we need to start by focusing on how we develop those soft skills. And one of the key things that enable soft skills to develop is the kind of health visitor supported good quality attunement that I spoke about earlier between mothers and babies, some of which can come about through good training, through things like video interactive guidance, but especially through preventing child abuse and neglect. And earlier Robert mentioned that the first year of life is the life in which a person is most likely to be murdered during their lifetime. It's also the year in which they are most likely to suffer abuse or neglect. And the second year is the second most likely for abuse or neglect. So in that crucial 2-year period, we should be doing everything we can to protect children and enable them to develop that eagerness to learn, which will create school readiness. And not only that, but pro-social, tax-paying citizens in the future, which is in all our interests.
What are the most effective interventions then at this point? What are you suggesting is the most effective way of dealing with?
I'm at danger of possibly repeating myself. Yeah. I think that on the prevention of the negative side, universal, starting in pregnancy, assessment of where additional support is valuable for parents, and the provision of that support, looking at the toxic trio and the prior generation ACEs, would be one place to start. Working with parents and giving more support to parents. In Sweden, for example, in Stockholm, 62% of parents in Stockholm attend parenting classes in the first 6 months of their child's life. I wonder how many parents in this country would think it's the natural thing to do to attend parenting classes in the first 6 months of their child's life. So that's one area that we can provide support. I also think this assessment at 3 to 6 months of age of the quality of interaction between mother and baby, carried out by health visitors, whether through home visits or through the Spanish PCPS program that I mentioned, followed by support through video interactive guidance, the PIP UK Parent-Infant Psychotherapy support, or the North East London Foundation Trust psychiatric support, would be the biggest set of measures which would transform school readiness in London.
And the Mayor putting his weight behind those interventions is something that you think would benefit the...
Absolutely. And as I said, I think there are ways that it can be done coupled with measures that would improve economics and unlock the funding to pay for it.
Thank you. Ms. Roberts.
Yes, I mean, I think, can I just say something about the programmes that Henry's been running over the last 10 years in the early years? I mean, thinking about parents attending programmes. The Henry programme is an 8-week programme for parents, in the first 5 years of life, but, as early as possible. And I think what we found has been really important about it, thinking about, what are the lessons and how to use that learning, is keeping it holistic. So not separating out parenting from health and from emotional well-being. So the Henry programme brings together parenting skills, whole family healthy lifestyle, emotional well-being, eating, activity. Because if we're going to equip parents to provide a healthier start for their children in terms of adopting healthy eating and activity habits, build very positive, warm, authoritative parent-child relationships, they need the skills, and so we have to link parenting skills with programs that are focused on a healthy start. So, I mean, we run this as the Healthy Families program. It's run in about half of the local authorities in England. We've had about 5,000 parents go through that program, and we know that it has been effective through evaluation in both building parenting efficacy, but also then leading to those kinds of changes that are about a healthy start. So, you know, healthier eating, food consumption, activity levels, but crucially, I think, reduction in parental stress and improved emotional well-being, because no parent is able to provide the best start for their child if they're struggling with multiple stresses in their life. So we have to bring together health, emotional well-being and parenting skills when we're supporting parents around school readiness and a healthy start more widely.
Can I just follow up with that? I mean, that to completely endorse that, and I think that was very much the vision of Sure Start when it was first conceived, which was somewhat lost sight of, that kind of that holistic approach. Just one thing to say, and this is a kind of both and kind of thing to say, is that in terms of accessing those sort of high quality group-based sessions, they are invaluable. But not everyone is going to access them. So some very Scotland is done a lot of research on growing up in Scotland, and one of it that study looking at health inequalities looked at the whole range of services and what was most helpful. So. One of the particular contributions of health visiting, which is complementary to the group-based settings, was that although all the mothers surveyed were positive about their experience of health visiting, on the whole, not every health visit is wonderful all of the time. They should be, but no, that's not about that. But those that reported the highest level of satisfaction with health visiting were those mothers who were the most socially isolated and the most socially deprived, who were the least likely to access centre-based or group-based activities because they might see them as being stigmatising or just too difficult for them to go to. This isn't at all a negative point around those kind of programs. They're excellent, but it's about how do you get there in the first place.
So, I mean, the program that we run is also delivered one-to-one with parents who, I mean, as a targeted program, because I absolutely agree, Robert, there's not every parent feels comfortable attending a group, but some parents also need more tailored support and that sort of one-to-one, which can be built into other support that's being provided for that family. And
their original question was around school readiness. This is how the young child before they're accessing a setting, be it a nursery or a school or what have you, they're in the home where they're going to have those opportunities to have a parenting experience where there's someone who is able to focus on their needs, to recognise their needs, instead of finding them a stress and a pressure on them most of the time, to begin to take an interest and a delight and a focus on them most of the time and shift that balance.
Can I just say that I think the key thing in terms of school readiness is that children have the communication skills that they need, and there are far too many children in London who start school they don't have the language skills that they actually need, and the services aren't always there to support them. So we need to make sure that we're identifying those children early on. We need to think about things like Book Start, which is...
is that language skills or English skills you're talking about?
Language skills.
Language skills.
So they're actually able to
Just
communicate, whether it's in the mother tongue or whether or not it's in English, but they need to be age appropriate in terms of they're going into an environment where there's going to be one teacher, one classroom assistant, and there's going to be 30 children. That's the reality of our education system in London. So those children in terms of school readiness need to be able to communicate effectively. They need to be identified early if there are issues around communication, and for them to actually have those resources put in place. And I think lots of areas, the waiting list for speech and language therapy is 4, 5, 6 months, which is a huge amount of time in a child's life, and in terms of them actually developing. I think the other thing about school readiness is children need to have independent skills as well in terms of their sort of social skills. So in terms of toilet training, we're hearing more and more children are going into school and they're not toilet trained. You know, they struggle in the classroom. We need to think about them being able to concentrate, turn take, their social development, actually their peers, how they interact with their peers.
There's actually more children having problems with toilet training.
Yeah, yes. Children are toilet training much later now. You know, the average age of toilet training used to be around about 2 to 2.5. Now it's more 3.
Do we know why?
We often as health visitors get phone calls from parents whose children are 3+.
But why
and are not toilet trained.
Have we got any idea why?
There's lots of reasons. I mean, I think it's multifactorial. I think it's parents are very, very busy nowadays. It's, you know, to toilet train your child successfully, you need to have time and space to do that. You know, parents are working full time. I think there is that move towards waiting until they're giving you the signs, which that parents are not always picking up, that actually their child is ready. But it is. I think we lead very, very busy lives. So children are now going into school not being toilet trained.
There's a whole area of questioning I'd love to do just on that basis, but we haven't got the time. So unless anybody's
they're not. You know, they struggle.
I won't.
They struggle.
I'm not going to do it.
They struggle at the dinner table because they have difficulty in feeding themselves because they don't necessarily have those skills or haven't been taught those skills. So there's a whole range of skills around them being independent when they go into school. Certain social skills that they do need to be able to function well.
Can I just ask one very quick? Do you not think that parents should start taking more responsibility for their children? I feel very strongly about this. The times I hear they'll learn it when they go to school, it's for the teachers to teach them this, that and everything else, and you've just endorsed that in effect. I mean, that goes back to early education for the parent, but do you think that a stronger hand needs to be taken on this? Because it isn't good enough, in my view, just my view, that we just expect teachers to take on the role of the parent more and more, to toilet train a child, to teach the child, to speak properly. That should be the parent's job. And it does seem to be getting worse and worse, and it's not fair to teachers.
But I think often parents don't realise the pressure that's going to be there when their child goes into school. So it is about us sharing that with them and explaining them and supporting them in terms of what the expectation is when their child goes into school and what it's going to be like. So I think that's about us getting
I think that's
across to
what
them.
we are saying quite consistently, Susan, is that we need to be putting support around the family right from the beginning and building parenting skills, confidence, so that they can provide
and make parents realise that it is their responsibility. Actually, it isn't the responsibility of all of the professions.
I'm not sure myself that parents don't think it's their responsibility.
I've come across lots of parents who don't think it's their responsibility. They'll let somebody else deal with it, and I personally don't think that's good enough. I don't think we should always rely on other people to do the jobs that we should be doing. It's wrong, in my view. It's wrong.
I think until we have a sense of actually how many people you're talking about and what percentage that is in terms of the London population, we can't say whether that's, it's an assumption to say that there's a majority of people who feel that way or not. So I'd be interested to hear, what you know, what percentage of the...
I'm sure this is part of the
little tangent
of the lifestyle we live in this world now, right? And because as we, my own observation is that the family structure have changed also, and this is part of it. I mean, I am a GP, apart from being here. There's some things I question. I got asked previously. They went to their mother-in-law or to the grandparent. And those things, those structures have changed, right? Okay, and I think we need to accept that, rather than that the family structures have changed. But I accept that parents have responsibility. But how do you support them?
Well, I think everything that's been said is about.
I mean, I sort of feel a need to fly a bit of a flag for parenting, because I think it's very easy to see what doesn't happen. And I know from having worked with parents for many years, I'm often humbled by what they're coping with, and the level of, you know, commitment and determination to try and do their utmost in what are often incredibly challenging circumstances. And so, yes, I mean, I'm sure that sense of building parenting efficacy is really important, and yet, you know, I wouldn't want us to lose sight of the fact that many parents are bringing up children in extremely challenging situations and doing their utmost.
I do accept that.
Okay.
That's it.
Obesity.
Obesity. Fiona.
Thank you. The Mayor's indicated that he's looking to take pan-London action on childhood obesity. What are the key elements that a pan-London strategy on child obesity would need? I'll throw that open to whoever would like to kick off.
That's a Henry type question.
Yeah, I was thinking that.
Shall I say a little bit about that? And yes, I mean, we've covered quite a lot of it. So, I mean, I think, you know, obviously we've had 10 years experience of tackling child obesity, and what I would like to share with you is our experience in Leeds, which I think is a very helpful case study. Henry has been embedded as part of the citywide child obesity strategy for the last 7 to 8 years in Leeds. And what is really important about this is the long term. So that would be the first thing that I would want to flag up, that any efforts to tackle obesity can't be piecemeal. You have to make it part of a long-term strategy, and you have to make that an integrated, multi-layered approach. So in Leeds, all of the workforce has been Henry trained. I mean, about 1,200 staff. So all of the health visitors, the community nursery nurses, the children's centre staff. We're now training all of the childcare staff, childminders and nursery staff. Within each children's centre cluster, there are the Henry Group programmes that we were talking about running, and they're running on a regular basis. We have community nursery nurses who are trained to do targeted one-to-one work for those parents who wouldn't be able to access groups. And we have volunteer Healthy Start mentors providing peer support to families within their own communities to overcome some of the cultural and language barriers. So what I'm sort of describing here is sustained, multi-layered intervention that includes workforce development and a range of intervention with families, really encouraging results as a result of some of this work, which is part of a wider, I'm not putting all this down to Henry, but it is particularly embedded in Leeds. And over those years, we've seen a drop in the rates of obesity in the most deprived areas of the city from about 14% to just under 10%. So the gap, if we're thinking about health inequalities, the gap is actually narrowing in Leeds. And I think that's really something that can inspire London in terms of thinking of really embedding this pan-London approach, that when you do think about all of the different areas you can intervene and then make that part of a long-term strategy, you can make quite an exciting impact.
That sounds really, really promising. So I think, why do you think, previous efforts to tackle childhood obesity haven't succeeded in London?
I would say that one of the reasons is that the focus has been too late. There's been a lot of work done on trying to turn around obesity in school-age children, and we know that once it's established, obesity is really hard to reverse. So PHE did some longitudinal data and released that in a report this year, which showed that only 1 in 20 5-year-olds who start school obese will be a healthy weight when they leave primary school. Whereas if they're a healthy weight when they start school, over 80% will still be a healthy weight at the end of primary school. And then the Health Survey for England showed that actually it's even earlier than that, because the obesity rates amongst 2 to 4-year-olds are around the rates that they are at age 5. So all of that suggests that if we're actually going to turn around obesity, we need to get in there right at the beginning, you know, sort of even pre-5. We're looking at pre-2. So I would say that one of the important things is bringing forward the focus. We have to have effective ways of supporting the children who are already obese. But if we're really going to turn the curve going forward, it needs to start much earlier.
Has anybody got anything else to add to that? Carly?
From Best Beginnings perspective, we do have a maternity obesity project in the pipeline at the moment to try and address some of these issues. Our focus is on maternity obesity and starting during the pregnancy journey, and having a focus on being non-judgmental and sympathetic and using positive reinforcement messages, so not chastising or saying, oh, you're overweight or anything like that, because if you're taking that approach, that creates mistrust, and someone, it's a likelihood that someone might step back and feel defensive if that approach was taken. We have a goal-setting feature within the Baby Buddy app, which can help with creating behavioural change. But I think there's also something to recognise here around food, smoking and addictions. The issues often being founded in self-esteem, and therefore it needs to be explored from what the root causes are. And just being able to be aware of human psychology, and that changes in behaviours take time, and there's not going to be a quick fix around that. If we look at our own examples of trying to change things and New Year's resolutions, how often do people give them up because they're actually really tricky to actually make happen? I think it's worth bearing in mind as well, again we come back to this, the nurturing and support of relationships with professionals along the way, more long term, is likely to create a more effective measure. And a couple of other areas to just bear in mind: the cultural and social influences on obesity. Particular communities might think it's a better thing to be a more healthy weight, or you know, and I certainly have heard in the Somali community before that it's healthier to be slightly bigger, so that there's possibility of dispelling that. There's also in the film and media the idea from in pregnancy of eating for two. And that's still there. It's in TV culture, it's in movies. So thinking about how to dispel that and getting some alternative messages out there that's actually not true.
I think there's 2 points, and they build on from what Kim has just said around the stages that we're measuring children. So we measure them before they go into primary school, and then when they go to secondary school. And it's too late. We need to think about measuring them at a much earlier stage, so those interventions can happen at an earlier stage. But secondly, there is evidence, I think, for children who are already overweight or obese, that some weight management services have been decommissioned, and that's because they're focusing on a very small number of children, and also the interventions are very expensive. So there needs to be some mapping work around weight management services and making sure that there is equality of access to those services, not just across London but across England as a whole as well. So those children that really have got serious kind of overweight and obesity issues can be managed, and to help them lose that weight and live healthier lifestyles.
Thank you.
I think just to say, all these answers, I think, support
Kim's point about that it's a very multi-layered thing. So, so at the outer layers, there's a kind of public health level interventions which we haven't really talked about, but maybe when we're looking at pan-London approach, maybe that should be part of our discussion. So we do have a national strategy. There were a lot of people who were disappointed that it didn't fulfill all their expectations, but at least we do have something there, and we're beginning to. There's it's legislation, for example, around sugar content of foods and drinks and so on. It's quite contentious, a bit like it is about having fluoridating water is contentious. We have terrible oral health in the northwest of England because we have soft water. Great for doing your hair, but it's bad for teeth. So, but it's been resisted. So healthy public policy is something that the pan-London approach is something that you might want to sponsor alongside those national things. And then down to it does chain right down to the individual. So one of the things that we haven't talked about at all, and I'm amazed, is maternal mental health. But you did pick up on mental health issues. So food is often used to meet non-nutritional requirements as adults and also with babies and children. You know, feeding is more than just about nutrients. So it can be used to pacify a child, it can be to keep them quiet, to stop them from being a distraction, or it can be, or also we can feed ourselves for those sorts of reasons. We've not talked about maternal mental health. It's a really, really important issue along these pathways.
The Health Committee produced a report on maternal mental health only a few months ago.
I just thought, I can't possibly, I could live with myself if I went away from this meeting never having mentioned maternal mental health. So I've done it.
Okay.
Yeah. Okay, well, thank you very much for your contributions. I'm sure this meeting could have carried on much longer, but time waits for no one. But if you think of something you want to say, which we said that, the opportunity is still there for you to write to us. If we find there is something we would like more information from, perhaps you'd be kind enough to provide that information
Just
to
to
us.
flag one specific thing, Mr. Hosking, right at the start of your presentation, you gave us some figures about health visitors. It would be great if you could share those with us after.
I actually brought copies for each of the committee members with me, so
brilliant.
I can
Thank you very much.
these.
Excellent.
That's
Thank
great.
you.
So please feel free to contribute if you want to carry on. And can I thank you for your time and your contributions. And can I ask the committee to note the contributions we've had? Okay. And also, can I please ask you the following recommendation: to agree the proposals of the Health Committee work programme, to agree the use of its next meeting on the 21st of February to discuss dementia in London, to delegate authority to the Chair in consultation with the Deputy Chair to agree arrangements for any site visits, informal meetings or engagement activities before the committee's next full meeting, including arrangements for a committee event workplace health on February.
Agreed.
And to delegate authority to the Chair in consultation with the Deputy Chair to write to the chairs of the London's 32 Clinton Commission groups regarding the committee's health report titled Preventing Sight Health Loss in London, and to the Mayor regarding the role and function of the London Health Board. Okay. And can I please ask the committee to note that the next meeting will be on the 28th of February at 2 p.m. in the Chamber. Good. Thank you very much.
Don't forget my offer to arrange a showing of the film